Okay, so after we saw uh, which is the etiology for this very particular disease and who is a candidate to develop the disease in the condition in which the contact with the bacteria seems to be not avoidable during a lifetime, and sooner or later everybody is entering in contact with it, but with otherwise no consequences in most of us. The very few which will develop the disease, first of all, should inhale, because the air is the main way for transmission of the disease. Possible other ways too, but this is by far 99.9% of cases are taken by air, so they need to inhale the bacteria in their lung. First, most probable moment of contact will be during the childhood period, and because they have a not yet mature immunity, they are at risk. And this is why, at least in poor countries, children are vaccinated for tuberculosis. And Western countries with very low incidence of the disease in general population consider that it's not necessarily. But even in Western countries, the contact with the Mycobacterium tuberculosis will be made somewhere in time, but later, probably in adult period, and in the adult period, you already have a maturized normal immunity. So with normal immunity, as I said, we will not develop the disease, but some reactions will be. Microscopical reaction, not clinically obvious reaction, so healing, auto-healing reactions, but some reaction will be. And these first reactions are described here under the name of primary pulmonary tuberculosis. For a child, most probable, but after all, it's only statistics, most probable area for the first infection to be localized is under the pleura of the middle right pulmonary lobe. And this is only because this particular area of the lung in children is the most aerated one, meaning the higher percent of air entering in the lung of a child will be there, and it's only probability, because otherwise this localization of the first infection is possible anywhere. Once the infection appeared under the form of 3 to 4 maximum bacteria, very slowly dividing, as I already commented, they have a very slow rate of division, one division each 3 days. So being here and very slowly multiplying these bacteria will trigger from the part of the body a reaction consisting in attraction at the site of macrophages. Polymorphonuclear cells are not able to phagocytate these microbes, and polymorphonuclear cells coming here and accumulating will phagocytate the bacteria without any result otherwise, because the bacteria is not killed by phagocytation. It's much too resistant for this. So by contrary, macrophages will be killed. And this way, at the localization of the first infection, very small but present necrotic area will appear. The necrosis consisting, in fact, in the necrosis of these macrophages coming here in a large number for phagocytation purposes. New other macrophages are coming, and more and more and more they will be accumulating at the periphery of the necrotic zone. Some of them in this accumulation will become elongated, called epithelioid cells, and even more, some of them will fuse and this way forming giant multinucleated Langhans cells. So at the periphery of the initially otherwise microscopic necrosis, a border of epithelioid and macrophages with giant cells is formed. At even more peripherically to this border of macrophages, lymphocytes will start to come slowly but surely. These lymphocytes for the vaccinated people will be able, from the first moment of their appearance here, being most of them lymphocytes T, to produce cytokines directed specifically against the Mycobacterium, which will block the division of this bacteria. So very early after the infection, a very small microscopic tuberculoid granuloma is formed, and by forming with efficient T lymphocytes at the border in large enough quantity, they will block the proliferation, and in this way the entire evolution of the infection is blocked. In time, very slowly, this very small microscopic tuberculoid granuloma will heal with a scar, and inside this scar the bacteria will continue to be alive for at least 20 years, but not able to escape and to invade other parts of the body. In those which the lymphocytes coming at the sites are not yet sensibilized because they were not vaccinated, they will be sensibilized locally on the first contact, for when it's the first time when the immunity is coming in contact with the Mycobacterium. So the entire process of reaching tuberculous granuloma efficient to block the proliferation of the bacteria will take a little bit more time, meaning it's not everything done in 1 week, but it will take maybe 2, maybe 3 weeks. But even in this period of time, the number of bacteria proliferating in the granuloma is still very low. So nothing is happening yet. The granuloma will be a little bit larger, maybe even visible macroscopically as a nodule. But at the end we'll reach the stage, this granuloma, the stage of efficiency to block the proliferation, and will heal with the scar, and everything will enter in the same way, in a sort of stasis, long duration stasis for the bacteria, and no any consequence for the infected organism. When it's larger macroscopically, this nodule, than 1.5 centimeter, it's even possible to see with naked eye the necrotic zone in the center, which is white cheese-like, and it's called for this reason caseous necrosis. Here is such a nodule beneath the pleura. It's quite larger because this case, one of mine cases otherwise, of a child who died with tuberculosis despite the fact that he was vaccinated. Vaccination was possible, not efficient, so not all vaccinated childs are efficiently vaccinated. So in some, it's in most of them 70% of something like that. The vaccination is efficient, but still remaining 20-30% of the vaccinated child with no efficiency of the vaccination, with an obvious risk for them that if they enter in contact during childhood period with the bacteria to develop tuberculosis. For this reason, from time to time, revaccination is indicated for these children, but only for a childhood period of time, because as an adult you don't need anymore because you already have a mature immunity. So here the granuloma formed beneath the pleura in the middle lobe was big enough to see that it's white cheese-like, the necrosis inside. So this is the initial nodule. And this is how it looks, with central necrosis and periphery with epithelioid giant cells and a corona of lymphocytes of the border, which, if it's strong enough in large number of T lymphocytes, because they are mostly T lymphocytes here, they will be able to block the evolution, the proliferation more exactly, of the bacteria inside the necrotic area. Here a larger view to see a larger area of necrosis in the center, the epithelioid elongated cells at the periphery with giant multinucleated cells between them, and the lymphocytes corona, which is quite thin here because it is image from a case with evolving tuberculosis, so which is was the tuberculous granuloma was not efficient enough to stop the proliferation of the bacteria, so the bacteria continue to proliferate slowly but surely to enlarge the granuloma, and at a certain moment even to disseminate in the body in different ways. See. So if the granuloma, which is formed, it's growing, so the reaction immune against bacteria it's not strong enough to block it, then by growing this granuloma with larger and larger quantity of necrosis inside, we'll be able to erodate first and most probable of all lymphatics, and biolymphatics to disseminate in the local lymph node. This dissemination, consisting in a primary lesion, consisting in the primary tuberculoma that we already saw it, lymphangitis, which is very rarely seen macro or microscopically, and lymphadenitis, meaning the appearance of granuloma in the local lymph node in the hilus of the lung. So the appearance of this combination of lesion is called Ghon complex, or Ranke complex from French language, both of them being equivalent and representing a first step of evolution. But this is happening only, so not only, but mostly in a person who have, at the moment of the primary infection, the moment of the infection, lower than necessary immunity, but for short time, meaning they will regain the normal immunity in about 1 or 2 months from the initial moment. And even now, despite the fact that the infection was disseminated, extended from the lung in the local lymph nodes, despite all this, in the moment when the immunity is regaining the normal status, all these lesions already formed will be healed with fibrosis, the granuloma reaching its efficiency, meaning stopping the proliferation of the bacteria, and everything happening in a context of no clinical signs, so completely asymptomatic without even knowing that it's happening. So maybe some of us stopped entirely the evolution in the moment of primary lesion, some maybe even reached the stage of gone complex, but we already healed without knowing and doing anything for it. Here from the case who died, so he was obviously not able to react efficiently against the bacteria. The primary lesion that we already saw it in the local extension in the hilum of the lung in the local lymph node. Somewhere in the between, it's possible to see eventually the lymphatic vessel affected by the bacteria, but I only see this lymphangitis, tuberculous lymphangitis, once in my life. And I saw hundreds of cases dying with tuberculosis. Another such an image with a local lymph node in the hilum and the subpleural location of the initial lesion. So the ranke or gone. So in 98-99% of cases, this primary or more evolved a little bit gone complex lesions will heal. And by healing with fibrosis, eventually even with deposition of calcium in the context of dystrophic calcification in scars, this bacteria will remain there forever or for at least 20 years, still alive but not able to disseminate, not able to do anything at all. When calcification appears, this calcification eventually will be possible to be seen in an X-ray routine examination, but radiologists are aware what is the significance. But if the immunity is low for longer than 1-2 months, then and only then will enter in the field of the progressive tuberculosis, meaning the real disease, the one who this time without treatment from outside will continue to progress and to kill. And the progression is possible to be made in different way. One way is to continue the lymphatic dissemination. It's already disseminated in the hilum, in the local lymph nodes, but from this hilum lymph nodes it's possible to disseminate in other lymph nodes more distantly. And at least for children, extremely frequent, the dissemination in such situation is to the laterocervical lymph nodes, which will grow in size without pain, without Celsius clinical signs of an inflammation. So looking very much like a tumor, pseudo tumor obviously, but like a tumor, enlarging the laterocervical lymph nodes. Here from the same case that we saw it before, another lymph node affected by caseous necrosis, peri-aortic, this being the aorta, peri-aortic, so meaning even more distant lymph node group than the hilar lymph node initially. And an image of such is not from that case, it's another case, not on one of mine. The laterocervical lymph node, meaning enlargement without Celsian sign, without dollar, without pain, meaning which is there present for a period of time, being suspicion for any clinician who is seeing that it's reactive to a local infection, adenopathia. Local infection who is drained here, it's from oral cavity. And children have almost continuously more or less degree of inflammation here generated by local microbes. So the pediatrician seeing such a lateral cervical lymph node enlargement will start to treat with antibiotic. For the pharyngeal, oropharyngeal, dental, eventually, infection. If in 1 week, 10 days, this adenopathia is not regressing under antibiotic treatment, then a suspicion will appear, meaning it's possible to be tuberculosis, as I said, because tuberculosis is not reacting at all to any antibiotic treatment. But it's also possible to be a lymphoma, which is a malignant tumor of the lymph nodes, which in children typically start to appear here in the lateral cervical lymph nodes, and it is called Hodgkin lymphoma. It's a particular type of lymphoma, particularly frequent in children with this very, very specific frequent localization to appear. So anybody seeing that you have such a thing, it's indicating a biopsy. The biopsy being necessary to make the difference between tuberculosis and the lymphoma. The lymphoma incidence is higher than tuberculosis, so in fact they will be sent to us as a suspicion of lymphoma. But fortunately, in some of these cases, we will find only. The enlargement can be so big bilaterally. And this image is coming from Venezuela, from a site dedicated for tuberculosis in Venezuela, an extremely poor country with extremely high level of tuberculosis there. And if it's staying untreated in this stage of giant lateral cervical tuberculous adenopathia, fistula, like in ordinary purulent inflammation, fistulas will appear lateral cervically, and the caseum inside this enlarged lymph nodes will be eliminated outside. The healing of these fistulas will be with very ugly deformating scars of the skin, which was called in the past, because nobody see it in the last century, such lesions. So older lesions were described as having scrofulosis. So the name of these skin lesions here was scrofulosis. With this fistulization, or even better with biopsy, having the diagnosis of tuberculosis, otherwise with no symptoms others than the lateral cervical adenopathia, the treatment is possible to be started and to heal it otherwise quite rapidly, efficiently in this still early stage of evolution, but this time it's a disease. Here how it looks with again whitish caseum cheese-like necrosis inside the lymph node. Another way for dissemination, much more aggressive. This time it's for the local initial primary granuloma by growing to erodate not lymphatic vessel but blood vessels. And by erodation of blood vessel, it's possible to disseminate if the blood vessel branch erodated is a branch of pulmonary artery which bring the blood from the heart in the lung. The dissemination will be only in the lung, but resulting in sudden appearance of thousands of small tuberculomas, microscopic initially, but growing slowly, and becoming in a particular moment visible on X-ray and macroscopically, but still very small, 2-3 millimeters only, and but in very, very large number, occupying both lungs, which version of tuberculosis called miliary tuberculosis. So it's a form of hematogenic dissemination, this miliary tuberculosis. If the vessel erodated one, it's a branch of pulmonary vein, which is leaking the blood from, not leaking, it's draining the blood from the lung outside in the systemic circulation, then the dissemination is possible to be systemic in the entire body, with appearing of the same miliary tuberculosis, but in any organ you can imagine. From brain to bones, from skin to adrenal gland. By the way, Addison, who described his disease called Addison disease, obviously the first described case in the world, was in fact suffering from tuberculosis of the adrenal gland. Such extension being in his case. So miliary tuberculosis, it's a very, very rapid extension this time, with appearance of thousands, if not hundreds of thousands of small granuloma, which will start to grow slowly but surely, each destroying obviously the lung or other organs, and for this reason it's considered to be a lethal form. In fact, in my experience already, I saw cases that even in such advanced dissemination phase, very severe, almost lethal condition, they start to heal by themselves without even knowing that they were touched by the disease. And the only thing they do, they start to eat well and moved in a mountain county where area where the fresh air combined with good healthy food was enough to regain the normal immunity and to start to heal all these thousands of lesions created, and everything without even knowing. This is such an image for a lung, with each this small white nodule inside being such a granuloma, still very small one, but in very, very large number, occupying the entire lung, called miliary tuberculosis of the lung in this situation. Each being in fact microscopically but growing slowly but surely tuberculoid granuloma with all the layer, but in most cases the external lymphocytic layer, being so many of them, the immunity it's not able to develop a strong enough reaction, as I said. And for this reason, the external lymphocytic area is thinner than should be. So they are still continue to growing, at least until the moment when the immunity will be able to regain its normal level. Maybe not here, nobody knows exactly if there are individual differences. In some, the reaction being stronger of the immune system, in some least strong. We can only assume that probably are such particular individual differences between us. Not all of us are reacting in the same way, in the same intensity, in the same time. So probably here, some will die, some will still be able to heal, even in some situation without knowing. Here is the same miliary dissemination, but this time in the spleen, looking in the same way in the liver, and in other organs, the kidney, for example. Another way for dissemination is for the initial granuloma by growing to erode the bronchial tract and the central area of necrosis to be eliminated in the bronchial tract to outside by coax, obviously. And this is the only moment when tuberculosis became infective. The patient with this tuberculosis, this type of extension became infective for others. Because otherwise, in all the other examples that we saw of dissemination, even in miliary tuberculosis, when hundreds of thousands of nodules are appearing in all the body, despite all this, as long as the nodules are not in contact with the airways to be externalized, the bacteria, the patient is not contagious for others. So he can be treated in ordinary hospitals or even at home. But for those in this situation with bronchial dissemination, resulting from the elimination of necrosis from the initial granuloma or other most recently formed granulomas to be formed cavities or caverns, all this one should be isolated in tuberculosis sanatorias, usually located in the remote countryside mountain locations to benefit from fresh mountain area and from a good quality of food. And obviously taking also the tuberculostatic medication for their disease. And in this way they will heal. And once healed the lesion and becoming not contagious anymore, they will be able to return to a normal life. But it's possible in some, fortunately very few. For this caseum in being present in the respiratory tract to be inhaled and to infect large quantity of the lung, generating a pneumonia or bronchopneumonia with tuberculosis. These lesions once appeared, if they appear, because it's not necessarily, they fortunately appear quite rarely. When they appear, they are lethal, so they kill. Here again from the same Venezuelan site, such images with caverns, cavities, and in the nearby pneumonia or bronchopneumonia with tuberculosis. In contrast with the ordinary microbial pneumonia or bronchopneumonia, which is healing, treated with antibiotics, this one are not reacting to the treatment. It's too late. So as long as I know, until now, all cases affected in this way died. The extension is possible even more, but much slowly, from the initial primary granuloma in the nearby region to appear another one, which will grow slowly and to disseminate in the locally only to appear another one. So this nearby to nearby extension, which is not mentioned in the slides, it's in fact by far the most frequent way, which is also an extremely slow way for dissemination, being for the most of time without any symptoms, without knowing that we have this disease with this type of extension. Sometimes these nodules can even be touched with the pleura and extending in the pleural cavity, and to generate here serous pleuritis, or sometimes, or even a serohemorrhagic one. Secondary pulmonary tuberculosis is considered to be a tuberculosis of reinfection. It's possible by being infected again later in your life than in childhood period, meaning in adult period of time. Infected again, but in the first moment you was with normal immunity, and now you are not. So developing the disease only now, despite the fact that in the past you had already the experience and you pass it very well without even knowing. Later, if you're in any moment of your life, after all, if your immunity is degraded for a reason or another by treatments, tumors, cancers, autoimmune disorders, transplantations, or by being poor and not eating well, just like that, then secondary pulmonary tuberculosis will start to develop, appearing again as a first lesion, first nodule granuloma initially. But for this age, adult age, the most probable location are in the apex of the lungs, and they are called, these first nodules, as Assman apical lesions. And they will continue to grow from here and to disseminate in the same way that we described it in the primary tuberculosis. So by lymphatics, by blood, by bronchial tract, or from nearby to nearby, and extending in this way in the rest of the lung, or eventually in the rest of the body. So it's the same disease evolving in the same way, in the same context of low immunity for long period of time. And healing again, if the immunity is regaining the normal level, or if the treatment with tuberculostatic medication is given. In both situations, spontaneous or help from outside healing, the healing is with scars, with fibrosis. And inside these fibrosis, calcifications eventually can also be seen and appearing. The problem with this healing, it's exactly the fibrosis, because okay, you will heal and you will finish to heal all the pre-existing in a certain moment lesion, and the quantity of scars in your lung will be as much as extended as your tuberculosis was before. So despite the fact that you healed, you will remain with a more or less severe pulmonary fibrosis, which will interfere with the normal respiratory function and will generate a more or less severe respiratory insufficiency. So it's preferable not to have tuberculosis, obviously, or if you have, to know it as soon as possible, to start the treatment as soon as possible, and to minimize the resulting pulmonary fibrosis from it. And it is possible in most situations. Here are the Ashman nodules on the apex, starting and disseminating. And the result of this dissemination, as I said, will be nodules with caseum. So nodular tuberculosis is called if they are the only lesions. Cavitary tuberculosis, it's appearing if these nodules enter in contact with bronchial tract. And I repeat, this with cavitary tuberculosis only are also contagious. And fibrous lesions, for those who are healing spontaneously or with treatment, the lesions. And the most frequent clinical, radiologically, pattern for this progressive secondary tuberculosis will be a mixed one, meaning a combination of some still nodular lesions, eventually with cavities, and fibrous lesions too. So a combination of all of this. Here we can see the first nodules being the largest one because they are the first and grow more long time. And by dissemination appearing miliary dissemination, cavities, meaning caverns with contact with the bronchia, and resulting from it also a bronchopneumonia, which was the killer in this case. So no fibrous lesions here because everything evolved so rapidly that this person probably didn't know that had tuberculosis and didn't start a treatment. Here the same, despite the fact that the cavity is small, very small ones, but there are many of them, and the extension was with pneumonia, tuberculosis pneumonia, again a killer, again without fibrosis in these images, because it was very rapidly the evolution. Fortunately, a rare way of evolution. The cavity, once they form, initially they were, as I said, nodules with caseum inside. The caseum being eliminated, but the caseum still remain for a period of time covering the inner wall of the caverns. This caseum being present there will continue to be eliminated as long as the treatment is not initiated. Because only with treatment we can stop this caseum formation, because otherwise, okay, the cavern initially small will add new and new necrosis layer on the wall, enlarging and enlarging. So it's evolving without treatment. With treatment, it's not evolving anymore. The cavity remain at the same size that was in the moment that you start. And slowly but surely, the entire caseum will be eliminated outside. In all this time, the patient being isolated in a sanatorium, and at the end, by fibrosis, these cavities will remain there. The patient will heal completely from tuberculosis, but the cavities will remain. And by their presence in the lungs, obviously in contact with the bronchial tract being, other infections will be favorized with other microbes. Mucus accumulation here, fungus can grow inside these cavities, microbes can also develop in this mucus accumulation here, and they will have, as a consequence, after healing from this type of tuberculosis, frequent respiratory infection with frequent bronchopneumonias or pneumonias with ordinary. Here another such a cavity or cavern mixed with micronodular miliary type tuberculosis, so a result of blood dissemination and bronchial dissemination. Complications, as I already said, is possible mostly for those with cavities. We can have bacterial infection with abscess formation in these cavities. Fungal colonization called aspergilloma, it's quite frequent and impressive. Possibility of large tumor-like fungal balls are called growing in these cavities. Extension to the pleura. The appearance in these cavities, which after healing, they will be epithelialized, the inner cavity, an epithelialization with normal bronchial respiratory tract epithelia will appear, but squamous metaplasia is very frequent. And from this squamous metaplasia, malignant transformation is formed. So they have a particular higher risk in time after healing from tuberculosis with cavities to develop malignancies. Hemorrhages are possible inside these cavities at any moment, sometimes being lethal. At a distance, being a very slowly but long duration evolving disease, it's possible in those which we already discussed, in those with genetic predisposition to develop secondary amyloidosis, the AA type, if you remember from that lecture, to extend by hematogenic dissemination in the entire body and to have a miliary tuberculosis in the entire body, or to extend by swallowing the caseum liberated in the bronchial tract to infect the digestive tract and to have a digestive type of form of tuberculosis. Here we have such a cavity which in his growing process eroded the vessel, and by this erodation and hemorrhage appear here, sometimes with hemoptysia, sometimes possible to be lethal. And fibrosis as a process of healing, when it's very extensive, will interfere in very seriously with the respiration. Now, a little bit more than the lung tuberculosis, because despite the fact that it is by far the most frequent affected organ, some other organs, as we already saw, can be affected. The digestive tract is one of the frequently also affected by tuberculosis, second in place, but at far distance from respiratory tract. And the digestive tract is possible to be affected primarily if, meaning as a first lesion, first contact of the bacteria being by digestive tract, usually because of consuming infected fresh milk from cows with tuberculosis. These cows infected with tuberculosis are infected with Mycobacterium bovis. It's a brother, close brother of Mycobacterium tuberculosis, but it's equally pathogen for humans too, not only for cows. So we can be infected in this way as a primary digestive tract tuberculosis. But in most situations, this digestive tuberculosis is secondary for the extension by swallowing the bacteria from aerial tract in the digestive tract. So a secondary infection after first being pulmonary tract infected. Here an image from the same children that we already saw some lesions. I tell you that he died. He had a miliary extension in his entire body. You can see it here on the surface of the peritoneal serosa, affecting the wall of the digestive tract entirely. Even the muscular wall of the serosal cavity was affected. So he had a tuberculous peritonitis by miliary dissemination. Otherwise, in the digestive tract, the nodules, the granulomas, being formed on the surface of the mucosa, will the necrosis in the granuloma will be spontaneously eliminated, resulting from this elimination ulceration. This ulceration being the marker, macroscopic marker for digestive tuberculosis, are always ovoidal, with the long axis of the ovoid being perpendicular for the long axis of the digestive tract. With the proper treatment, the healing will generate stenosis because of this perpendicular disposition of the ulceration, stenosis of the digestive tract, which is possible to generate occlusion or subocclusion of the digestive tract and being necessary to be operated eventually. Here are such ovoid ulceration, even with perforation from the same case that we saw the peritonitis first. We still can recognize these small whitish nodules on the surface. He had also digestive tract tuberculosis with even perforation. Here, miliary dissemination in the liver, and again with caseous, caseum accumulation between the diaphragm muscle and the liver, meaning in the peritoneal space, so with peritonitis. It's not from my cases, but it's a very nice image. Here the miliary dissemination in the liver, and here from one of my cases in the liver we can still recognize here the trabecula of hepatocytes with a nodule inside without central necrosis being so small and formed entirely only by the elongated cells of epithelioid cells with the giant multinucleated cells inside. So the granuloma here is not have the necrotic central core and don't have the external lymphocytic crown because it was so inefficient in such massive total body this blood dissemination of tuberculosis. The immunity was completely overwhelmed, and the reaction was only able to do such a thing, so to accumulate a nodule of epithelioid cells with giant multinucleated cells. By blood dissemination from lung, it's possible for tuberculosis to be filtered in the kidney, obviously, because the kidney is a filter for blood, and to disseminate in this way in the kidney from initially pulmonary lesion. For this reason, the renal tuberculosis is always secondary. So it's not possible for the kidney to be primarily infected, only secondarily by blood. The result will be appearance of initially one or more than one microscopic granulomas which will grow. And by growing, we'll see, by growing these nodules, they will be able to form large granulomas. And some of them are able eventually to erodate in the pelvis of the kidney and to eliminate the caseum in the urine, in the urinary tract, infecting in this way the pelvis and the entire urinary tract. But also resulting from this elimination of caseum initially formed to produce cavities in the kidney. So we can also have cavitary lesions not only in the lung but also in the kidney, and obviously this person being infective for others by their urine. It's an extremely low probability for somebody to be infected from the urine of somebody else, but by sexual contact it is possible. Here the nodules growing slowly but surely in the kidney, and eventually at the end destroying entirely the kidney without cavern formation. It's another way for kidney tuberculosis to evolve. Both of them destroying the kidney and making necessarily, if unilateral, the lesion, the kidney removal to stop the dissemination of the tuberculosis, or for those which are bilateral, obviously you cannot remove both of them without the price of entering in hemodialysis. So in such situation, the tuberculostatic treatment is given with the hope that the lesions will be stopped, healed, and the remaining function of the kidney will be enough for a survivor. So from this point of view, we have a medical renal tuberculosis type, which is treated with tuberculostatin treatment, or a surgical renal tuberculosis type when we need to be removed, when it's only unilateral. Like in this situation, having such extended destroyment of one kidney, he is necessary to be removed and hopefully to escape the other one from being. As I said, by sexual contact, extremely rare but possible to have genital tuberculosis. For men, it's possible also to have an infection of the prostatic gland, of the epididymium, and even of the testis eventually directly by blood, so to be secondary. But also it's possible primarily from sexual contact to have this dissemination, but only in the prostatic gland and epididymium. So the testis will be, when easily infected, is by blood dissemination from a previously pulmonary lesion. For women, primarily by sexual contact, the uterine cavity and fallopian tube will be infected, and the ovary, when are involved, are secondary by blood dissemination again. And here is such a miliary type with small nodules, dissemination in the prostatic gland. Here in the tuberculosis in the testis itself. And here is the tuberculosis of the uterine cavity with dissemination from the cavity in the fallopian tubes too. By blood, only by blood dissemination is possible to have infection of the central nervous system, taking the form of a meningitis, which is called basilar meningitis because it's the infection localized always on the basal face of the brain. This is typically for this etiology only. Otherwise, the other microbes, when are generating meningitis, are doing on the convexity, so on the other face of the brain, the basilar type, it's always tuberculosis, and looks like white, milky, like liquid presence in the subarachnoidean space in this area. At microscopic level, being some very small miliary granuloma eventually here present. But also it's possible to take the aspect of large granulomas in the brain itself, also by vascular dissemination, and being so large, they are called tuberculomas. And here it's such an image. Another organ eventually possible to be infected by secondary by blood dissemination are the bones. It's possible to be infected the backbone when vertebral bone is destroyed with extension of the necrosis to the nearby muscle, paravertebral muscle, generating a collection, a very large collection of caseum riding the backbone, which is deformated because of destruction of the vertebra. This particular type of extension of tuberculosis from backbone to the nearby muscle is called morbus of Pott. But also it's possible to have infection of long bones and even of articulations. And in this way we finish the discussion about the prototype disease for granulomatous inflammation, respectively tuberculosis. It's a quite long discussion because it is a very important disease. And now a little bit shortly, if it's possible, for me at least, to discuss about syphilis. another particular infection which can generate granulomatous inflammation, but only in the tertiary phase of evolution. Because otherwise, syphilis generated by Treponema pallidum, it's an acquired disease by sexually transmitted, but also possible to be transplantary, placentary, vertically transmitted in the fetus when we discuss about congenital syphilis. The sexually transmitted, horizontally transmitted disease start at the site of the sexual contact, mostly being obviously the case of the genital organs, with the appearance of what is called primary syphilis, taking the form of an ulceration with a firm base on palpation called firm chancre. It's this lesion is painless, and it is healing by itself with antibiotic or even without antibiotic treatment in about 2 weeks. If it's not given the antibiotic, the bacteria is also disseminating from the local initially firm chancre to the local inguinal, obviously for the genital organs, lymph nodes, generating increase in their size, meaning lymphadenitis. And remaining after healing of the first chancre, spontaneous without antibiotic healing, remaining this primary syphilis with the bacteria alive in the lymph nodes, locally lymph nodes, for many years. From this localization of lymph nodes after about 2, 3, 4 years of staying dormant, the treponema is escaping in the lymph circulation and by lymph entering in the systemic circulation, generating a generalized form of syphilis called secondary syphilis. The secondary syphilis, it's characterized by appearance of a skin eruption called roseola syphilitica or syphilides. They are affecting the skin with even the hairy skin where it's generating alopecia, but also the mucosas undertaking the form of white plaques on the mucosas. They appear and disappear without any treatment, appearing again and disappearing for a few months, and after that they will disappear completely for many, many years, around 20 more years. And after these 20 more years, the tertiary syphilis will appear only, and these tertiary syphilis have gomas, and these gomas are granulomas, tuberculoid type of granulomas. In the secondary syphilis also, at the site where initially the firm chancre was present, condyloma lata can appear, and also generalized micropolyadenopathy, meaning all the lymph nodes in our body will be enlarged, but very, very little enlargement. This is why it's called micro, but polyadenopathy. And remaining as generalized micropolyadenopathy for this next 20 years. Obviously, at any moment, from the first infection moment to in any other moment of this evolution, antibiotic, if it's taken, will kill this treponema. It's very sensitive even for the ordinary penicillin. And by killing it, the evolution from primary to secondary, from secondary to tertiary will be interrupted. This is why in our time period now, when we have antibiotics at our disposal, we are seeing extremely rare the secondary and the tertiary syphilis forms, because eventually the primary syphilis is still present in the population, but being, even without knowing that you are infected, taking for other reasons, for completely other reason, antibiotic, you will heal from the syphilis without even knowing in some situation that you was infected. The history of the disease has its particular importance. It was imported, in fact, the treponema from America by Columbus and his sailors. And by this import, the Portugal and Spain was first infected. This is the official story, but in fact, quite recently, proofs came to demonstrate that before Columbus even, Vikings imported the disease in Europe, and they discovered skeletons of bodies with goma of the skeleton. Very, very characteristic lesions otherwise, so impossible to be confused with anything else. So such skeletons were found in Scotland and other maybe zones conquered by Vikings in the Viking era. But they didn't disseminate in the rest of the Europe, because on that period of time, being the early Middle Ages period, the sexually transmitted disease were very difficult to be transmitted because of a very high level of morality in the population. Because of religion, obviously, and because despite any religion, the morality was in fact maintained at high level by inquisition and other such forms of punishments of sins. So with Viking dissemination, only local dissemination happened in some part of England, but in the Renaissance time of Columbus, when they come back with the disease, they find a low morality period of time with a lot of cases being sexually infected, and with the surprise of the fact that in America, the population, local population infected, nobody knows for how long time, they enter in a sort of tolerance with the disease. So they develop the disease and they die from it, but very, very slowly. As I said, from the moment of primary infection, at least 20 years of living, which is the case for us now too in Europe. But it was not the case in the first century of infection. In that particular time, after Columbus, the primary syphilis evolved in secondary, and after that in tertiary syphilis with gomas in less than 5 years. So very fast evolution. And this evolution was killing them on in large number, the population. And everybody was scared about a new disease, formerly not seen before, even not having a name for this disease. For this reason, Spanish population give to the disease the name of Portuguese from which they get the disease. And it was called in Spain as the Portuguese disease. But they also give the Spanish, the disease, to French people, and they call it Spanish disease. And after that, French soldiers of Napoleon wars disseminated the disease in the entire Europe until Moscow, Rome, Cairo, even all these directions in which Napoleon had wars in his period of time, he disseminated with the help, obviously, of his soldiers, the syphilis in the entire Europe, and after that, the entire Europe was infected. In most of these other countries, the name of the disease was the French disease. In time, as I said, the European population adapt, and they start to evolve much slowly in time, as it was the case for American population. But in our days with antibiotics, we finally have a cure for it, because before no cure was possible. This is how it looks, the hard chancre, obviously in the male genital organ, here also in the male genital organ, and here on the skin of the female genital organ, but possible also to be located on the surface of the mucosa of the vaginal tract. When they are there, they are hidden to the sight of vision and they remain unknown. And these unknown contaminated persons are the most dangerous one, because they obviously will disseminate without even knowing the disease to others by sexual. For our days now, the oral cavity being also a sexual organ somehow, obviously such primary hard chancres can appear even here in the oral cavity, anywhere from the lips to tongue to pharynx, any location. And this is how the roseola syphilitica looks like, the skin eruption that I said. It's a systemic eruption without pain, without being itchy, so no symptomatology at all, and disappearing for a few months, and after that disappearing completely until the appearance of tertiary form. The white plaque here is the equivalent for the eruption, skin eruption for the mucosas, possible to be healed after penicillin, like in this image. The flat condylomas are appearing at the site where initially were the hard chancre located in the primary syphilis period, so affecting the genitalia, male and female. At microscopic level, this first and second phase are characterized by intense infiltration with plasmocytes in the wall of small vessels of the affected tissue. So we don't have a granulomatous reaction in this period of time. It's only this plasmocytes in very large number in the surrounding of small vessel, local small vessel, capillary or arteriolar or venular. The tertiary syphilis is the only one generating granulomatous lesion called goma or gumatous syphilis. But also it's possible to generate diffuse infiltrative lesions like in the other previous two phases, but this time located mostly in the around the small vessels, taking the same aspect of plasmocyte infiltration, but in the surrounding of small vessels in the wall of the aorta. So in the vasa vasorum of the aorta, this lymphoplasmocytic infiltration will generate the syphilitic aortitis, which will generate aortic aneurysm And this aortic aneurysm by breaking will become lethal. And this is how they died in the past in large number, extremely impressively, because they are dying by a rupture, a spontaneous, apparently, rupture of the aorta without no reason at all. It was scary without knowing what is happening. But all these gomas or diffuse syphilitic aortitis are not seen in our days now. These are such goma lesions of the skin from a very old atlas of pathology, a German one. Here other such images, looking very much in this image with lepra, which is another extremely rare disease in our day, but also generating granulomas, which sometimes affecting the bones, including the palates of the oral cavity, and generating this infiltration with plasmocytes around vasa vasorum in the wall of aorta, which will generate an aneurysm with potential killing break. Also, such gomas are possible to appear anywhere in our body. When it was described in the past, obviously, in the liver, in the most frequently in the liver, but also possible in the brain. And Vladimir Ilyich Lenin died in this way by syphilis. And now it's now official. The congenital one, it's meaning the transmission from the infected mother to the fetus. If the transmission is very early, meaning in the first 3 months of evolution of the fetus development, the fetus will die. So it's generating a form of congenital syphilis which is incompatible with life. And it is like that because it's generating gomas in the placenta. And in this way, the fetus will be not able anymore to be nourished, so or to be respirated, oxygenated, so he will die. When the contamination of the fetus is a little bit later, meaning after the 3 months of pregnancy evolution, but before 6 months, so in the period between 3 and 6 months, an early form of congenital syphilis will appear. Being compatible with life will consist in very early, meaning from newborn or not or soon after that, appearance of a skin rash, very much similar with the roseola syphilitica described in secondary syphilis in adult. And this skin rash will develop other local lesions like rhinitis, hepatosplenomegaly, anemia, mental retardation, hydrocephaly, so a lot of other lesions associated, but the skin rash is the main attracting attention for this. This is the only image I find on internet with such an early type syphilis congenital. Because otherwise, if the transmission of infection from mother to fetus is later than 6 months of pregnancy evolution, late form of congenital syphilis is developed, which consists in appearance much later after the age of 5 or even 6 of lesions, consisting in the what is called Hutchinson triad. So they are characteristic for the children, but not very early, after the age of 6 around, or even later. And this Hutchinson triad consists in keratitis, which is an infection of inflammation of the cornea inducing blindness, labyrinthitis of the acoustic nerve, which is an inflammation of the acoustic nerve generating deafness, and an infection of the permanent teeth generating the Hutchinson teeth, which in fact are affected only the central incisors, superior and inferior, which became conic with an incision of the, not incision, it's a deformation, a central notch of the incision surface of this conically deformed central incisors, superior and inferior. They are called scalariform teeth. A goma of the nose, meaning of the bone of the nose, is possible eventually to appear, or even osteoarticular osteochondritis periostitis can appear in this particular late form of congenital syphilis. And these are the Hutchinson teeth, meaning the conic superior incisive teeth and these notches of the central incisor being very characteristic. And the bone of the nose being also deformed by the presence of a goma here. And now we finish the syphilis and we'll start to see some other particular inflammation but this time not necessarily granulomatous. They are particular inflammation because they are generated by etiologies which are possible to be identified by us. So in the most inflammations, we are not able to identify the etiology. It was the virusology, microbiology, allergology, and so job to do the etiology, not for us. For us just to describe that it's an exudative, is serous, fibrinous, purulent, hemorrhagic, necrotic inflammation, granulomatous inflammation, but not saying anything about etiology. For tuberculosis, it was possible with Thiel-Nielsen to identify the etiology, but also it's possible to identify this etiology in some other few, but very few etiologies, like in actinomyces Israeli infection. Despite the name actinomyces, it's a microbe. It's not a mycotic inflammation. But it's growing in large colonies always, and for this reason it was confused in the past with mycosis, and in this context it was given to it the name of actinomycosis, but now we know that it's a microbial infection, and obviously being a microbial infection should be treated with antibiotics and not with antimycotic treatments. Otherwise, it's a commensal microbe in the oral cavity and remain like that as long as the immunity is normal. In the context of decreasing the immunity, it's possible to become pathogenic. And it is becoming pathogenic by invading and diffusing from oral cavity to other locations. For example, most frequently by far, but remain an extremely rare condition, the extension is by lymphatics from the oral cavity to the head and neck lymph nodes, where the lymph nodes will become enlarged without pain, and inside these enlarged lymph nodes, a lot of small abscesses will develop. This is why the microbe is acting very characteristic, generally small but numerous abscesses. So not large abscesses, but small and large number. And all of these are able to generate fistula to the lateral cervical skin. So a lot of fistulas are possible to appear in evolution. Otherwise, without fever, without clinical signs of any kind, but necessarily an antibiotic treatment when it's discovered. The same actinomyces israelis is possible to be inhaled in the lungs, and in the context of a low immunity, because otherwise is inhaled daily, but nothing is happening in normal immunity condition, but in low immunity condition, in the lungs again will appear the same thing, a large number of small abscesses, each of them being able to generate fistulas in any direction, as we already discussed when we discuss about acute and chronic abscesses in the lung. Another possibility is to be swallowed in the digestive tract. And being swallowed, this actinomyces israelis has a very particular affinity to the cecum, and will generate here abscesses in the wall of cecum with possible perforation and peritonitis being generated in this way. I am seeing it very, very rarely, this actinomyces in the lumina of appendix, which is the appendix, an extension of the cecum itself, and probably being the etiology for this appendicitis. But also possible for this cecal actinomyces infection to disseminate in the portal vein blood, and by portal vein blood in the liver, and generating here a very, very large number of small abscesses. So all of these are described as particular forms or clinical forms of the actinomycosis, but they are all of them possible only in this context of very low immunity and are treatable with antibiotic. A quite new particular form is described in the last period of time, appearing frequently in the uterus, meaning in the uterine cavity. Pelvic actinomycosis is appearing frequently in the context of intrauterine device, persistent for a very long time. Here is how it looks, a lateral cervical adenopathia with fistulas on the lateral cervical skin eventually appearing. The microscope is quite unique with a separate image. Here the intrauterine device present in the uterus. If it's forgotten there for more than 5 years, these intrauterine devices can trigger the appearance of an intrauterine infection with actinomyces, which eventually can extend from the uterus to the fallopian tube and the ovaries. It's described more recently. And this is how it looked, the colony. Otherwise, in a collection of pus, meaning in necrosis with polymorphonuclear cells, like any other pus, the microbes colony here are particular. Normal colonies are basophilic, meaning they are blue, deep blue in hematoxylin and eosin. This one is not. It's partially blue, partially red. We are calling this type of coloration as amphophilic, so not decided what to be blue or red. The amphophilic coloration of the colony, which is quite large, and at the periphery, some filaments are seen of the periphery of the colony, mimicking the sun. And for this reason, it was called actinomyces. It was believed that it's a mycetes, it's a fungus, and it was compared with the sun. This time a real mycotic infection, not the only one, but the only one that we'll discuss about, being by far the most frequent, is the infection with Candida albicans or candidiasis. This Candida is also a commensal presence in our oral cavity and digestive tract, where it's present in a very small number, but normal presence being, in the context of a normal immunity. And normal eubiota, meaning a normal presence of a large quantity of different type of microbes in the digestive tract. These microbes consuming the most of the nutrients, the Candida have, being in concurrence with the microbes, will remain without nutritive support, and for this reason it's remaining in such small number as a normal presence in the digestive, because the microbes are consuming the support, the nutritive support of the Candida. But this equilibrium between microbes and Candida will be completely destroyed in the context of prolonged treatment with antibiotics. So any prolonged treatment with antibiotics will favorize the appearance of digestive or even systemic candidiasis. Other local favorizing factors are trauma, burns, ulceration, surgical intervention, and moist environments, this time for the skin. From local infections to systemic infection, the possibility to become systemic of Candida is possible in the context of immune deficiencies of any kind. So immune deficiency like in AIDS, like in hereditary immune deficiencies, we have in children such syndromes called DiGeorge or Nezelov syndrome, in which the thymus is absent congenitally. They have such immune deficiency, and I saw and I have dead little cases of candidiasis resulting in this context. But also diabetes, malignant tumors, leukemias, endocrine disorders, pregnancy even are able to induce the appearance of systemic candidiosis or local eventually. Treatments, long-time treatment with corticoids, cytostatic treatments are all with immunosuppressive effects. So as a result of local or systemic factors, we'll have a local superficial candidosis or a systemic disseminated candidosis. The superficial type can affect the skin folds, generating eczemas, the fingernails, generating onychomycosis, or the mucosas, generating mostly in the oral cavity that white plaque covering the surface of the mucosa, but also possible in the external genitalia or vaginal mucosa location too. This white plaque, it's scratchable. It's possible to be scratched. And in this way, we already discussed, it's made the difference with the leukoplakia, leukoplasia, another white plaque appearing in the oral cavity. When it's scratched beneath the white pseudomembrane on the surface of the tongue, remain a congested red mucosa. Sometimes when candidiosis is in small quantity, so is candidiosis, is pathologic, but otherwise asymptomatic. In small quantity, being the deposition of candida, it's not seen as a white plaque, but it's seen only the congestion between it as a red plaque. And the persistence for long period of time on the surface of the tongue of red plaques, it's also suggestive for candidiasis. and should be treated as candidiasis with antimycotic treatment local. Otherwise, white plaques, onychomycosis here. On the palate, not only on the tongue surface. And when is extended in the esophagus from the oral cavity, then it's pathognomonic to be this extension in a very severe immunosuppression condition. Initially described in AIDS patients, but now it's described also in post-transplantation cases or other severe immunosuppressions, like in cancer, for example, treated with chemo cytostatic treatment. This is how it looks from one of my with DiGeorge cases. The surface of the esophagus with squamous mucosa, ulcerated and covered with this black stained hypha of the candida in a silver stain, arginmetanamine, silver metanamine, particular special stain for mycosis. Smaller view for this hypha or hyphae of the candida. They are possible to invade from local extension initially in the, mostly from the lungs, to invade in the vessels and to become systemic with septicemia. In such a situation, we can assist to the appearance of endocarditis with candida, abscesses with candida anywhere from kidney, lung, brain, liver, and also to appearance of meningitis, enteritis, arteritis, osteomyelitis generated by candida. Here being such an abscess with candida in the kidney in one of my cases. And now the last particular etiology that we are discussing in this chapter of inflammation. So this will be the last slides. Pneumocystis is generated by Pneumocystis giroveci as it is considered to be a fungus in our days, but for many, many years it was not very clear what it is really. It was considered to be a sort of mold. It is not an ordinary fungus, it's a mold more exactly. And have a brother called Pneumocystis carini affecting animals, and for humans it's called Pneumocystis giroveci, the etiology. It's pneumocystis, meaning it's taking the form of small cysts affecting the lung, and is generating a pneumonia with pneumocystis, in fact, which macroscopically these affected lungs are very much alike with the pancreas. So it's a pancreas-like aspect on the section of the affected lung. Obviously for those who are dying, because otherwise clinically the diagnosis is made differently. And at microscopic level consists in the appearance of in hematoxylin eosin of a foamy liquid in all the alveolar spaces, also with infiltration of the septa of the alveolar spaces with a lot of lymphocytes. It also was called, and it is still called in the literature, as interstitial plasmocytar pneumonitis. So consists in this infiltration with plasmocytes and a foamy liquid. In this, again in a silver impregnation stain, we can see the pneumocystis itself, taking this aspect of small, very small cystic figures in this foamy liquid in the alveolar spaces. It's possible to have this infection with pneumocystis in two different situations. In premature newborns, in the context of hospitalization, so being a hospitally transmitted infection, in premature newborns, when they are diagnosed correctly, they are healing with the proper treatment consisting otherwise in Biceptol, nothing else. It's a quite simple treatment, but you don't give such a treatment if you don't have the diagnosis. So if they are not treated properly, they are dying. But if it's treated, once treated, it's cured without relapse for the rest of the life. So no other relapsing possible after such a correctly treated. The other type of patients possible to develop the same pneumonia, it's in the very severely immunocompromised patients. And until now, it was described only in HIV or congenital severe immunodeficiency like the George syndrome. I had such cases. They are in this particular special year that we are living now, also described in context of COVID-19 infection. So in this context of AIDS or other such severe immunosuppression, mortality is very high, being associated this pneumocystis infection with other etiologies. It's airborne and have microscopically a very poor inflammatory response, meaning the plasmocytic infiltration of the septa is almost not present at all. So it's only the foamy liquid in the alveolar spaces being seen in these patients, not the rest of inflammatory response. With the proper treatment, it's possible to be healed, but it's possible also to relapse again and again